starting the recording. Thank you everyone for joining today. Before giving floor to Dr. Aala El-Khani, I would like to introduce myself. I'm Gülşah Kurt. I'm a clinical psychologist and doing my postdoc at University of New South Wales in Australia. And I'm coordinating the implementation of the Caring for Carers project, where we provide an online clinical supervision to mental health practitioners working with the displaced communities in Turkey, Northwest Syria, and Bangladesh. Our principal investigator, Dr. Rutvels, is here with us. And we are organizing this event as a part of our webinar series in the Caring for Carers project. For those who would like to learn more about our project, I'm pinning the link to our project here in the chat. You can have a look. And today we will be talking about the family skills and the resources to support earthquake-affected families in Turkey and Syria. In the first half of the session, Dr. Aala will present available tools to support families and how to use them. And in the second half, we will hold a Q&A session. We are delighted to have Dr. Aala El-Khani with us today. I would like to briefly introduce her before giving floor to her. Dr. Aala El-Khani is a humanitarian psychologist, works as a consultant for the United Nations Office on Drugs and Crime. She is also a research associate at the University of Manchester at the Division of Psychology and Mental Health. Aala is passionate about highlighting the significant role that caregivers play in protecting their children during crisis. Aala researches and develops innovative ways to reach families that have experienced crisis, conflict, and displacement. She is a developer of numerous family skills resources, as well as a global trainer of family skills program and research methods. She has conducted training in over 25 countries, including Uzbekistan, India, Indonesia, Sri Lanka, and Palestine. And her TED Talks have been viewed over 1.5 million times. Now I would like to give floor to Dr. Aala El-Khani for this important webinar series. Thank you so much.
Thank you, Gülşah. Good morning, everyone, from a typically rainy Manchester here in the UK. Firstly, I'd like to thank Ruth Wells from the University of New South Wales and Gülşah Kurt for reaching out and inviting me to speak with you all today. So thank you all for everyone who's joining. I'm not sure who exactly is with us or who's joining and from where, but for those of you who are in the field in Syria and in Turkey and themselves have experienced the earthquake firsthand, let me first start by saying I'm really sorry for what you've been through and any loss that you've experienced. As a Syrian myself, I know that this has come as a disaster within a disaster. Can you see my slides okay? Is it all clear? Great. Okay, so the current humanitarian context in Syria and in Turkey can really make us feel quite hopeless. Such large numbers of people affected in the most devastating ways. Where do we start to help, and what even needs to be prioritized? So what I hope to do in my presentation is to plant some seeds of hope, that despite the awful circumstances that families have been through, with the right tools and the resources, there is so much that we can do to help them recover from their experiences and empower them so that adults and children can go on to lead healthy lives. I'm going to be sharing with you lots of open access tools and practical ways of how we can use these, from examples from the field previously and now in this context too. I'm going to spend about 10 minutes to begin with, just taking us through why supporting caregivers is so important and should be focused on. And then I'm going to jump to the actual tools and how to use them. There'll also be an opportunity to be able to register for some trauma recovery intervention training in the weeks ahead towards the end of the presentation. I just want to focus here on how I'm going to use the word caregiver. So caregiver here really represents the primary caregiver of any child. This could be the parent, but in circumstances where there is no parent, for whatever reason, this will be the person that the child is being looked after the most. Okay, let's start by considering first what families will have gone through in the last 5 weeks. I'm going to show you a few photos and we can reflect on these together. So here in the first photo, this could be the first hours, maybe the first day after the earthquake. We can see extreme fear, confusion, insecurity, a really devastating image. Some of you will have been there and will have experienced this yourselves. For those of us who weren't, we can only imagine what this must have been like as a civilian. You know, what's going through your mind? Maybe we can all take a moment to think about it. You're a mother, you're holding onto your child's hand really tightly. We have friends in the field and colleagues that we've spoken to, and they've shared thoughts that they had during this initial time, like, where is the rest of my family? Did they get out alive? Who's still missing? Where can I find safety? How can I keep my child safe? Is there access to healthcare? Because right now I'm bleeding. So there are basic necessities that need to be addressed first, because these civilians were still in survival mode. And this photo now, maybe this is fast forwarded to week 3 or week 2 or 3 of post-earthquake. There may be an acceptance now that of what has been tragically lost. So who was injured, the loss too of physical safety and shelter, and caregivers will likely be experiencing a really suffocating amount of grief and pain for what they've been through. And they may have becoming more aware now of the changes that they will be seeing in their children's well-being. Those that are having nightmares, those that are showing real fear and depression, becoming more clingy to their caregivers, bedwetting, for example. And what about now? So let's fast forward to where we are today. There will be many families that are displaced. Some will be living in shelters, homes, temporary accommodation, or have moved on to a new location. And if this was you, it might be you, what would you need now? There may be some kind of roof over your head, your immediate needs for shelter, potentially access to food, maybe some kind of healthcare may be available, but you will still have lots of stress and anxieties for sure. For many people, the situation is still incredibly desperate, even if they have a roof over their head. They may have reached a realization too that they aren't going home. This is their new reality. And it's at this stage where we often see really different varying mental health and family problems really begin to increase, like child abuse, substance misuse, physical and sexual violence. Under threat circumstances, such as crisis or attack or displacement, caregivers can become less warm and more harsh, and levels of parental stress can become a really important driver for this. The distress and the challenges that are experienced by parents can really compromise how they parent, how they care for children. That's in their mental health and in their beliefs in their own self-efficacy as a parent or as a caregiver. And it's at this stage that families might still be in denial of what their future holds, or simply really just unsure. And we definitely can't predict what's going to happen to these families, but we absolutely have a duty of care to provide them with all the possible physical, practical, and psychosocial services that they're going to need.
What did you bring? Mug, nice.
So the family is a social institution that is so powerful in the lives of children, and we very often underestimate the role of the family in prevention of so many different negative outcomes, though the family is so important. There's an assumption that caregivers just simply know how best to care for their children when they become parents, but that actually isn't true. It's really not that simple. Children don't come with a manual. And those of us here who are parents ourselves will know it's far more complex than that. And living through a crisis such as an earthquake really entails many changes for the child and for the family, with the potential of a really big impact on the well-being and mental health of children and caregivers, both acute and long-term. But here is the key message. The relationships that parents or primary caregivers have with their children is the primary most important factor in their future well-being. That's in their emotional and mental health development, and really significantly in reducing the likelihood of them becoming engaged in other risky behaviors like drug misuse, criminal activity, or any activity that can be harmful for them in the future. All families in all contexts, all around the world, can really benefit from family skills resources that promote family protective factors like communication, trust, problem solving, conflict resolution, and families that engage with parenting information are much more likely to have better mental health, physical and social outcomes in the future. But what about families that are experiencing parenting under significant stress or challenges, such as those that have experienced the earthquake? Well, research on family skills implementation work tells us that families need these same things that I've just mentioned, but that in extreme stress contexts, they need to focus even more on the family. Things such as a focus on relationships and strengthening family protective factors are even more important now. We need to focus on how to deal with adult and child stress, the importance of listening and communicating with our children, the value of using love and limits in our parenting with our children and how to do this, ways to encourage positive behavior so your children are listening to you and complying with your safety instructions, for example, and how to discourage misbehavior that can put them in severe danger through this crisis that they're experiencing. During crisis situations, the role of the caregiver is only further magnified. Often the family or the caregiver is now the only support institution that remains when everything else is lost. And sadly, research tells us that children and families that are going through a crisis are more likely to experience violent discipline from their caregivers, and actually children can become even more at risk. Even though we know that children can be protected by warm, secure parenting. And this is why at UNODC, we've been focusing for many years now on developing parenting resources for families that face crisis around the world. So I've mentioned family skills, programs, and resources, but what are these? These are resources that aim to strengthen these family protective factors that I've been mentioning, such as conflict resolution, the importance of listening and communicating, and ways to encourage good behavior in our children and discourage misbehavior. There's a focus in these programs and these resources on relationships and behavior change and practice. Practice is a really important component in these. And families that engage in these kinds of resources and tools are more likely to have better mental health, physical and social outcomes in the future. And also, those of you, I know there'll be some managers here and maybe policymakers who are leading the funding for these programs or programs for families that have been through this crisis. It's important to note here that supporting families is very cost effective, with research finding a return of almost $10 for every dollar spent implementing family skills programs. So there's a really good return too financially and how we can use family skills programs in our implementation work in crisis. I spent a lot of my early career conducting field research in refugee camps as part of research at the University of Manchester with Professor Rachel Calum, where we did research with families who were experiencing conflict and crisis and displacement, and just sitting with them and asking them how they were coping and what they needed support with in caring for their children. And since that time, we have conducted many studies with families in very various humanitarian contexts and exploring their needs and what their needs are and their challenges with caring for their children in these crisis contexts. And what we found is that families in humanitarian contexts massively struggle to care for their children. The adults affected by the earthquake will be watching their children's behaviors and emotions dramatically change. Their children could be bedwetting, thumb sucking, they might become terrified of loud noises, having scary recurring nightmares, becoming more aggressive, maybe more withdrawn and depressed. Those of you in the field will have been seeing this firsthand. And parents will likely have no idea of how to deal with this. And how can we expect them to? How would they know how to deal with this enormous change in their children? And even more worrying is they likely will not know how to get support and how to access such support. And this is why the work we're doing today and we're talking about is so important. So in response to this identified gap of an enormous need for help, but then very little being done in the field, we have developed over a number of years at UNODC and the University of Manchester this pyramid model of interventions to promote strong relationships within families and good mental health for children and for their caregivers as a preventative protective strategy. And we've brought these together with a number of other resources, and we have a stepped model of parenting through challenge settings. And we've developed a work around this model where at each level of our model that I'm going to take you through now, families can be provided with support that is dependent on how much resources the area that they're residing in has and how much need there is. And I'm going to touch on all of these briefly and show you ways that we can do this practically. So let's start at the bottom of our model here in yellow. And here we recognize that all families that have experienced the earthquake will need basic parenting information. So on this universal level, here we provide very light touch, basic parenting skills, tools that can be distributed very easily. Here are some examples of these. Before we had this meeting, was having a chat with Gulsa and with Ruth, and we were talking about how many of you in the field will have very short interactions with the families. And you leave these interactions thinking, have I given them everything I possibly can in this short time? This is really where these kind of light touch tools can be incredibly valuable. For example, looking at this, I know they're coming up quite small for you, but we have a leaflet, for example, a double-sided parenting leaflet. I'll just point to it here, which has basic parenting information on, first of all, normalizing what you as a caregiver might be experiencing, the changes you might be experiencing, and how you can help yourself. And then information on what you might be experiencing in the changes in your children, and information on how to help them. Really basic information such as trying to maintain some kind of routine within the chaos that you might be experiencing, taking time to listen and talk to children, taking time to really give them the information that they need to feel safe, but not to overshare with them unnecessary information that can make them feel scared. Taking time, if possible, to allow children to play, taking time to interact with our children. Things that caregivers may have known before the earthquake and may have been doing, but in the chaos and in all of what they went through, they may have pushed it to the side because they were busy with other things. These same kinds of written information leaflets, which are just double-sided, so can easily be disseminated, and I'll talk about how, we have the same information as videos. So as you can see in these orange boxes here, these are just stills from short videos. We have them, all of this in Arabic and in Turkish and in English and many other languages. So for families that maybe are illiterate, or for contexts where you can share the video much more easily on WhatsApp or any other messaging platform that you can access. We have other tools here that you can see in these colored boxes, which are interagency light touch tools led by the Parenting a Lifelong Health and Ending Violence Against Children and many other interagencies. We have lots of tools as well, very pocket-sized, easy to disseminate information such as how to deal with grief, how to deal with the loss of someone, how to talk to children about this, how to keep your children safe from trafficking and other dangers, how to communicate with children efficiently. Really short information that can be disseminated very widely. An example here of how we can disseminate, this is an image from, I think this was 2015, in research that Professor Rachel Calum and I did in Syria, where we disseminated these very light touch parenting information leaflets inside bread wrappers. So we worked with a local bakery inside Aleppo. It was actually the only bakery that was disseminating, providing food, which was bread, to families in the area. And we simply we provided them with the leaflets and asked them to insert these leaflets into the bread wrappers. Very, very simple methodology. And here we actually did a research study alongside the implementation, where we disseminated 3,000 of these, and also a questionnaire inside these bread wrappers, and also a pen. I think you can see this from the image, asking caregivers about how useful these leaflets were for them. And we had an astonishing response rate of almost 60% of families in a war zone in Syria engaged with the leaflets and returned the questionnaires. and rated at almost 60% of the leaflets as quite a lot useful or a great deal, really showing us that even in crisis, families want information on how to care for their children and will really engage when they're given a chance. We're working with a group now in Syria, Action for Humanity, and we know that we had some wonderful images of them distributing mattresses alongside a booklet that I'm going to talk to you shortly about, or distributing cooking oil alongside a leaflet as well, or airdropping with their phones to families in a long queue in a bakery, the video I just shared with you of how to look after your children. So there are so many ways, and you will be much more informed and know how best to be innovative in our approach to giving these tools to families based on your local experience in the field. This is the website. I will share it again later, but this is our UNODC website, which has all of the resources that I'm going to be talking to you about. They're in Arabic, English, and Turkish, and many other languages too. And you will find it all here. I also want to bring your attention to the right slide here, which is the mhpss.net website webpage, and it has an enormous number of tools as well. While my presentation will be on the tools that we are using at UNODC that are evidence-based and we have a lot of experience of using over the years, there is also an enormous amount on this page too if you want more information on other tools that might be useful. So please do look at both of these after these for a range of tools and different intensities. Okay, let's go back to our model here and jump up one level. So here in green, this is recognizing that when we do give these light touch information, families are usually asking for more information. So the next level up takes us to more intensive and more stable environments where we're able to give more intensive information. And here for this earthquake situation, we have a booklet, which is about 28 pages, called Caring for Your Child in Crisis Situations. So it has really wonderful information on how to build parental confidence, how to regain your self-regulatory skills through this crisis, how to enhance child and family psychological well-being, a lot of practical tools, tips, of how to care for your children through this crisis. And this comes alongside a associated conversation group seminar. So along with this booklet, we also have available for you a PowerPoint presentation and notes on how to run this PowerPoint presentation. So if we take this example here from Palestine, families who are taking part receive this booklet, but they also take part in a group setting where they are watching the presentation and having a facilitated conversation group discussion with the other families, sharing their experiences and learning from each other. And this can be really valuable in your context too. Families are in temporary shelters. You have access to hundreds of families under one roof. So I'm just imagining this for you, how you can gather them in groups of 50, 60 families together, hand out these booklets for them, run these conversation groups and allow families to share, and then move on to another group of families the next day. So there's so much you can do with this booklet as well. These are just some themes for the booklet. So things such as normalizing to the caregivers what their children might be experiencing, normalizing to the caregiver what they might be feeling, and that this is normal to feel anxious, depressed, have nightmares, feel an enormous loss of control. There's also information on how to keep your children safe in this context, how to provide warmth and support, understanding the different anxieties and worries that children will have and how to speak to them about it. So you can see this more when you yourselves can access the booklet, but this is just an idea to show you what's inside these booklets. Moving up now in our model, we come now into the orange level, which takes us to more broader, focused, interactive programs. So whereas before we had a very light touch interaction with families, now in this level sits multi-session programming. So as we go up in this model, the programs are becoming more intensive and will require training. So for the case of this earthquake, this level will be particularly useful for the wider communities at this stage who may not have faced the severe trauma experiences, but will be experiencing stress. And we can do this through multi-session work with them when we know that the families will be in one place for the duration of the program, which is about 3 to 4 weeks. And this is the level where you will need some training. I'm going to give you an example of one of these programs. It's called the Strong Families Program. And this is a UNODC program that's evidence-based and is a universal program for all families that have experienced some kind of stress and is trauma-focused. And families, their children and their caregivers would take part in this program together. And it's designed for families in a way that it's very light. So you don't need a lot of resources. Training can be face-to-face, or it can be through us remotely. You need very little to run this program. Really, it's just about having space and the ability to print off some papers. We've trained this program in over 25 countries around the world and have an enormous amount of evidence now to show its effectiveness. And this is really something that I hope you can explore after this webinar and look at how you might use this program with the families that you're working with. Just to give you an example of what this program consists of, we have caregiver sessions, child sessions, and then we have family sessions where the children and the caregivers come together. In the caregiver sessions, for example, we explore the parents' challenges, how to deal with their own stress. We talk about how to use love and limits in our parenting with our children and how to listen to children. Child sessions, again, we do a lot of work on how to deal with stress and teaching techniques on how to deal with stress and talking about the importance of rules and responsibilities. In the family sessions, caregivers and children have a chance to practice these different kinds of skills that they've been learning with each other and to practice positive communication. And yeah, I'll park this here with you, but there's lots of information on the webpage that I'm going to share with you. Here are some photos of our implementation around the world from Strong Families. We have worked in many humanitarian contexts, in Serbia with Afghan refugees, for example. So lots of humanitarian contexts. But back to our model now, what about interventions for children who need more specific, tailored trauma recovery work because of the earthquake experiences? And this level of the intervention is really important for us to focus on too. There will be thousands of such children who need specific trauma recovery work. And I'm pretty certain those of you who are working now directly will have seen a wide range of trauma in children and their caregivers. And one of the main benefits of the light touch tools that we've been speaking about before at the lower levels of our model is by interacting with families at the lower stages and by beginning conversations with families about parenting, excuse me, we can identify who needs this more tailored, intensive trauma recovery work. If we're not working with families in our communities at all, with parenting and caregiver support, how are we going to identify who needs this more help? So by working at every level, we will be able to know who needs this more tailored work at the top of the model. So at the top of the model sits the Children in War Foundation program, Teaching Recovery Techniques, TRT. This is an evidence-based child trauma recovery program that is being used globally. Actually, this program was first developed in 1999 in response to the earthquake that happened in Turkey. So this has come full circle now for us to be implementing this work again here. The original intervention has sessions for children. So it's a child trauma recovery program in its essence for children who score high on trauma measures. And I'm shortly going to go into the components of this child program. But what we did at the University of Manchester, myself, Professor Calum, and one of our other colleagues, Kim Cartwright, was to add a stream of parenting sessions to this program as well. So in the TRT plus parenting version, not only do the children take part in trauma recovery work, but their caregivers also learn the same trauma recovery work, recognizing that they will also have trauma and need to support their child's trauma. But the caregiver will also be learning essential parenting skills. And we've piloted this enhanced version called TRT plus parenting in Syria already, and in Turkey and in Lebanon, and found that when parent sessions are added to the original child trauma recovery program, mental health, behavior, and parental feelings of self-efficacy are far more improved. And we are going to be running several cycles of online training for this program in the coming weeks in Arabic and in Turkish. So for those of you who are interested, I will leave my email at the end, and please do reach out to register your interest so we can involve you in this. So here are the main components of the child trauma recovery work or sessions. We work on intrusive thoughts, arousal, and avoidance. So you will have maybe experienced in yourselves or even in the children that you're working with, that children may be having intrusive thoughts, remembering what they're experiencing, having flashbacks, not being able to sleep because of nightmares. So we do a lot of work on working around how to manage this and how to recover from this. A lot of work too on arousal. The children may be in a state where they're highly aroused. They can't sleep, they're so stressed, they're terrified, and also avoidance. They may be avoiding the certain areas that remind them of the earthquake, even certain people, certain routines that they might have had before that remind them of the earthquake. They might be avoiding going to sleep because it's a reminder of when the earthquake happened. So all the activities we work around are working on these three components. For example, for the intrusive component, we do a lot of work on sleep hygiene. A lot of the children may be having nightmares right now, recurring, terrifying nightmares. So we do a lot of work on first supporting the children on developing a safe place in their mind, a place they can retreat to when they have these intrusive thoughts or worries. And then we work through their nightmares by allowing them to speak about them, to draw them, and then to draw a happy ending for their nightmare while they're awake. So when they sleep, they can process their nightmares better. For example, this is an image here of a child who was having recurring terrifying nightmares of planes dropping bombs on their city in Syria. After taking part in the program, the child was able to draw this happy ending to their nightmare of a plane dropping gifts and not bombs. And this child's nightmare significantly reduced after engaging these activities. So this is just an example of the kind of work we will be doing with the children. If we look now at the specific parenting sessions, there are 5 sessions, and we'll be looking at a range of activities such as to normalize to children, to normalize to caregivers their children's reactions. Also, how to give effective instructions to their children so that their children comply with their instructions. This will really help to keep their children safe. How to praise and encourage children to increase the good behavior that we want from our children. How to manage challenging behavior. We want to really try to reduce as much as we can any harsh behavior with children. So we give other strategies of how they can manage challenging behavior that caregivers might be experiencing with their children. And very importantly too, how to listen and communicate with children and how caregivers can take care of themselves as well. So in summary, we really need to make use of this really wonderful protective shield that caregivers can be for their children through their early development and through adolescence, and recognizing the importance even more during challenging, stressful times. And we do this by ensuring access to family skills resources. Caregivers are often already really motivated and might even be seeking help. And we know that family skills programs can be delivered even when funds are very, very low. And we recognize too, of course, that UNODC pyramid is just one example of how support can be conceptualized. Of course, there are other programs and other resources available that I will link that you can also use. But right before I close, can we just spend 1 minute thinking about the toll that this work might be having on yourselves? You might be exposed to trauma yourselves. You might be going through a really tough time yourself, and then you have to support others. So how does this affect your own mental health? A 2015 Guardian article reported really worrying findings that on mental health in the aid sector, where 79% of those working in the aid sector had experienced mental health issues like anxiety and depression, and also panic attacks and PTSD. And many of you will be doing really important work right now without much practical training or on self-care or how to look after your mental well-being. And this really shouldn't be the case, that you should be able to access some support yourself. There's a really wonderful organization that I've come to know of in the last few weeks called AMNA, and I've left the link there. I would really encourage you, whether you're working individually or part of a larger organization, or if you are a manager of an organization, to look at this group. They provide really wonderful services, such as how to create safe spaces for children through this crisis, but also how to look after your own well-being and the well-being of your team. And they have lots of practical tips and workshops that they're running throughout these weeks. So please do have a look at them too. And finally, as much as we really desperately want to, we can't wipe out what has happened and the traumas that the families had been through, even though we desperately all want to. But let's recognize that if we focus on what we can do, which is supporting families with the tools that we've just mentioned and many others that you can link to, and also referring families to more intensive support, you are able to help families in their recovery and to weaken the link between this crisis and any potential psychological difficulties in children and the caregivers in the short and the long term. I think I've gone over slightly too much, but here is my email. If anyone wants to reach out for anything, including registering for the TRT Plus Parenting Program. And here is my Twitter account too. Thank you all for your attention, and I'm happy to take any questions you might have now or via email later.
Thank you so much, Dr. Aala. Thank you very much for this extremely informative and insightful session. As you very well articulated, we are in huge and urgent need of evidence-based, easy to implement, scalable resources and tools to support distressed families during this time. And your presentation and all the information that you generously shared with us was extremely helpful. I'm sure that our colleagues in the field working with the affected communities at the moment will benefit a lot from the resources. We shared the website links in the chat, directing us to the resources that you mentioned during your presentation. People can see it there. And again, once more, thank you so much. I would like to open the Q&A session. I'm sure there are many people with lots of questions to you. Nurper Hanım, please go ahead.
Okay, thank you very much. Thank you very much, Aala. It was an excellent and inspiring presentation. Thank you very much. And so many good examples from around the world, and also good examples in Turkish, Arabic, and other English languages. We've been already preparing some materials for the field, and already in touch with AMNA and having good session last Friday. I have two very simple questions. One of them is very simple. This double-sided parenting leaflets and these colorful messages that I think 13 different small boxes. I wonder if we could, if UNODC could help us to turn them into a more they're nice, but they, as you said, maybe literacy, there might be some literacy problems, there might be some time problem that they don't want to go and read them all. Would there be any possibility of turning them into more comprehensible illustrations? And for example, each pink, yellow, or whatever, these 13 messages could be turned into one or two kind of one-side page. But each one of them, I have them here, okay? Each one of them could be turned into a small brochure, two-sided, with illustration. And that would be very, and also similarly, that double-sided parenting leaflets would also be turned into small brochures that, for example, when we went to the field, we could hand it out to the parents, to caregivers, and to professionals who would like to have some very specific and brief messages to be conveyed to the families? That is one simple question, and it would be very helpful if you and ODC did come up with something like this in Turkish, Arabic. Would be very, and soon, would be very useful. My second question, I don't want to take the floor again, is about the level 3, the level 3 program, and you said it originated from earthquake in Turkey in 1999. It's almost 23 years, 24 years since then. And is there any follow-up on this? What happened to those children and families who have been through that program? Has there been any study, any follow-up study, or any impact assessment that we could come up with some results on children and people in the long run? It would be very helpful. I hope there is one. If not, this time we should not miss this unfortunate opportunity to do it. So, thank you.
Thank you so much, Nurpa. It's lovely to see you, and thank you for the incredible work you've been doing since the beginning of the earthquake as well. To answer your first question, your point was really wonderful about can we use these resources in other ways? So, for example, I'm not sure if Katie Murphy is with us, but Katie Murphy, for example, I think it was through UNICEF, if I'm not mistaken, or was it? Gosh, I can't remember now, but maybe it was UNICEF. They used the tools on a Facebook page and made them as illustrations. So all the information in the leaflets were changed into simple messages in almost a cartoon way to become more engaging to the caregivers.
Excellent.
So absolutely.
So let us have them.
Yeah, sure. I will share the Facebook page with you after this. The most important thing is to stay close to the message. We don't want the message to change because the messages in the leaflets are evidence-based. And the same thing for the messages, the ones that you pointed out, these colorful squares, these same squares that you said where there's 5 in one page, there's another version where there's 1 in every page. So much more easier to share. So you're welcome to use these. And I know Lucy Kluver from University of Oxford also had this question a few weeks ago. And our response is always, please do use them in the ways that you see fit and in the ways that you can engage families, but just stay really close to the key evidence-based message. And that's fine. So I will share after this, maybe I'll share it with you, Gulsa, and you can share it with the group, the Facebook and the other interactions where people have changed some things to make them more engaging. But it's also very easy, Nurpa, just to hand out a double-sided leaflet as well. And that's what families are receiving. A double-sided leaflet is also quite light touch.
Yes. Yeah, this is what we will do, but it would be useful to have some illustrations as well.
Sure. And your second question about, so it was the level 4 that we said is the TRT plus parenting, the really trauma-focused work, child recovery work. In 1999 was the first implementation. This was by the Children of War Foundation. So I'm not sure really if there was a follow-up, but I will certainly ask them for you, and I will come back with the response I get. There has been many published studies over the years of short and longer term follow-ups, and I'll have a look if I can find something and share with you. But Children of War Foundation's TRT program comes with a lot of evidence-based. Yeah. I'm looking at the chat now, and I see many of our colleagues are typing in Arabic that they would like an Arabic version of this webinar. So thank you for those who messaged. Gulsar is absolutely working on that. Thank you. And I will repeat this likely next week in Arabic. And Gulsar also mentioned that likely we will have a Turkish translation. So we will let the whole group know again when that's going to happen.
Well, actually, we might also ask for the Turkish webinar at one point. There's no Turkish translation. I did check.
Yes,
there isn't at the moment.
Unfortunately, we couldn't arrange.
So this was a kind of introduction, and it would be great if we could also have the Turkish version of this webinar later on.
Yeah,
or translation.
Salah and Ruth, please go ahead.
Please, Ruth. Okay, no one. Hello. Thanks, Ruth. Hello, Dr. Ala. This is highly appreciated. I am one of those who waiting and asking for Arabic webinar, another one. This will be highly appreciated, actually. And thanks for your time and what you're providing us today. I'm Salahuddin Liggi. I'm psychologist. I'm working with C4C, Caring for Carers Research and Hope Revival Organization. Actually, the question related to TRT, Teach and Recovery Technique. Majority of Syrian MHPSS workers in Northwest Syria, especially using Teach and Recovery Technique. It's very, let's say, common interventions. But here I would like to, let's say something, and I need your comments. I received training about Teach and Recovery Technique, and I used this intervention as prevention intervention. And in the first page of this manual, they mentioned this is not therapy. This is not to treat those who are suffering from post-traumatic stress disorder. I'm sure I remember this sentence in the beginning of this guide, let's say, or manual. What I'm noticing the last, let's say, 2 years, a lot of practitioners, and this let us think again about the supervision and the rule of supervision. A lot of practitioners mentioned to me when I visit Northwest Syria, when I provide training or supervision, etc. We use it with everyone. We use Teach and Recovery Technique with every child. I asked about the pre-post questionnaire, which is there in this manual. They mentioned it's okay, even if he has a high level or symptoms of traumatic events, they will accept him. I think this is something doing harm, because at the end, those who are suffering from kids who are suffering from post-traumatic stress disorder, let's say, they need individual interventions. They need intervention from psychologist or psychiatrist or counselor or someone individually, at least, even if he's psychosocial worker in the third level of IST. That's what I would like to mention. And thanks a lot for your time, and thanks for everyone.
Thank you so much, Salah. I appreciate that. I will definitely repeat in Arabic. My Arabic is not as good as my English, but we will definitely have an Arabic webinar. Back to your question on TRT. TRT is absolutely used for children who have high PTSD. So that is actually one of the inclusion criteria. So usually we do the CRISE questionnaire, where we measure their PTSD or their trauma experiences, and those with high PTSD are the children that are included. Usually what happens in earthquake or natural disaster or conflict contexts is that majority of the children, or a lot of the children, will have high PTSD. So in some contexts, we're seeing TRT used with all children, acknowledging that, for example, everyone in this earthquake context who lived through it and had the severe destruction will have some kind of trauma or stress. And in other contexts, maybe when it's used a year or two after a war, for example, then we measure the children's trauma, and then we do it only with children who have high PTSD. For example, we did this in Lebanon with children who had been displaced from the Syria conflict, and we used the CRISE questionnaire with, I think it was 350 children, and we found almost 75% of them scored high enough to be included on the PTSD measures for the program. So even 2 years after a war. So I'm assuming in this context, it will have a similar effect as well. So we absolutely do use it for children with high PTSD. Of course, we recognize that after the children take part, there may be children and adults who, of course, will need more specific one-to-one therapy, Salah. And this is something we definitely need to have available as well. I'm not sure what is available to your field teams now, but I know that during the Syria conflict, there was a lot of remote sessions that were able to be provided. I know organizations such as Awesome, UOSSOM, I'm sure you work with them closely, had many therapists who were working on a one-to-one basis. So this is the top level. I have presented it as a top level, but of course there will be families and children who will need actual more intervention. So I hope I answered your question, but for sure the TRT program will be absolutely essential for the children who score high on PTSD.
Thanks, Dr. Ala. It looks a huge argument here related to TRT, because the others, specialists trainer, let's say in this TRT, they recommend to choose those people or kids who are suffering from PTSD or high level of PTSD and to refer them to specialists before accept those kids again in the program. Of course, they can be part of the session, but after going to, let's say, specialists, maybe image cap doctor, maybe other psychologist or counselor. But I totally understand the situation in Syria context, of course, in Northwest Syria and in Lebanon, Jordan, Turkey, etc. So yes, thanks. I totally know, of course, USUM and other MHPSS practitioners in Northwest Syria. So thanks again, Dr.
Okay, thank you.
Thank you so much for the really beautiful presentation. And I feel like when I hear these kind of talking about these different skills like warm parenting and praise, how to give praise and so on, I guess I'm always keen to hear how people talk about how to do that. And I was just wondering if you could talk a little bit more about what, praise might look like, and what warm parenting might look like, and if there are any specific cultural elements that would be specific to the Syrian context in terms of giving praise. Or, sometimes giving praise might feel strange and not normal. And so how do people kind of overcome that as well?
Yeah, it's a nice question, Ruth. We do a lot of work on praise, so how to praise children, and really it's about engaging with children. So we talk about, it's about spending time with children. It could be even just having eye contact with children. We worked, when we were doing research in a refugee camp in Syria, for example, it could simply be even drawing a smiley face in the mud for a child when you're happy with them, to show them you're happy with them. Of course, there are cultural differences. So we talk about, it could be putting your hand on your child's shoulder, giving them a kiss. And then we talk more about how to praise your child. So the kind of words we use, so praising specifically is very important. So rather than say, good boy, we say, thank you for picking that up when I asked you to. I really appreciate that. So we do a lot of practice as well. We give examples in these leaflets and in these tip sheets, but when we have scope in the more interactive work, we do a lot of role play as well of how to use praise. And of course, that looks different for every culture and for every family. And praise is really important to focus on because families can become quite harsh when they're in survival mode or in crisis. So reminding them of this more gentle approach of their children and engaging with them is really, really important.
Dr. Omar?
Hello, Dr. Ala, and hello, everybody. Thank you for your nice presentation. I still recall in HRO in 2016, we had a project, and that was trauma focused, and it was based on TRT, teaching recovery techniques. I still recall the final report, and there is the pre and post evaluation, and I recall that we went into dilemma because the results were showing that more kids have depressive symptoms, and some of them have traumatic symptoms after the intervention. And we did a great time. We spent a good time looking after why we have that results. And ultimately, we found out that these sessions were conducted in schools, and in schools, that time we had the Russian bombardment ongoing, and the kids or the teachers were pressing on the team to not utilize, to just finish up with their intervention rapidly. They give them one certain class day to do their work. And ultimately, those who were offering the service, the MHPSS practitioners, were doing some sort of mistakes in communicating with children, so that led to bias in the results. And we traced a lot of those kids, and we made a single assessment. Psychologists assist them, for depressive symptoms, for PTSD symptoms, and ultimately we found out that was the problem in the in how we offer the intervention. It is not that the kids have really this problem, because if it would have been so, we have to do the private intervention, which was difficult at that time. And in my opinion, the issue was with lack of supervision. We needed a supervisor who was well versed with the TRT, because as far as I know, I'm working in the Syrian context since I'm Syrian, and I did my post-graduation in Syria, and part of it was during the crisis of the Iraqis. You know, a lot of Iraqi kids were working in, were staying in Syria. I worked with the UNHCR, and then I came to the Northwest Syria context and in Southeast Turkey. And ultimately, we don't have much trained people working on trauma at that time. Still, so far, I don't. I think that we need to know what is our capacity in dealing with trauma-affected population, especially children. You know, and I think that the system in Northwest Syria is based on MHGAB practitioners, and their intervention in child psychology and child mental health problems is very limited. Even for those Arabic speaking in Turkey, the interventions are very limited. And if we will, again, I really appreciate the technique, the TRT technique. This is one of the very few techniques that enable us to work with traumatized children. And it does not need the, let's say, the high qualification we need for private interventions. This is why I may agree with you on with the colleagues who are using it for in Northwest Syria, because there is no other solution. We have 70 trained psychologists, and I'm not sure how many of them is well versed in dealing with traumatized children. And I think this will be, we have to, if we are going to implement it, we need to make sure that this is context related. It is appropriate for the context. And number two, that those who will be trained on it should have proper supervision, so we don't end up with negative results. And sorry for the long speech, and thank you once more for the well-organized presentation and for resources you provided us.
Thank you, Dr. Ahmad. Just in response to that, that was a really good example of how important it is to do research appropriately and have appropriate supervision. So this is why we haven't reacted yet and run training yet for TRT, even though we're 5 weeks. It's been 5 weeks, because we need to make sure we're going to be training the right teams and have the correct supervision. So it's really important to have that in place. With regard to the research component, this should be completely separate to the people who actually run the program itself. And often what can happen in situations in the field is that the same facilitators who are running the programs are also doing the evaluation component. So the research can get very messy, or there's very little training. The research itself needs somebody who's skilled in the research component. So I can totally understand why some problems in the research can happen, but I'm really glad that you recognize how valuable TRT has been so far. And I hope TRT Plus will continue to be in this context. Thank you.
Is there any
Can I just mention, Gossa, I just noticed that Professor Rachel Calum is with us, who has worked with me for the last 10 years on this work. So if there's anything, Rachel, that you'd like to add that I haven't or I've missed, your input would be massively valuable if you think I've missed anything.
Hi everyone. Aala, that was a really great presentation, and you just sum up all the work so well and so clearly. I was actually looking at trying to find the answer to the question that Nurpa was asking about the evidence base, the long-term evidence base for the Turkish earthquakes. And it's clear that the programme was very much in its development at that stage, so it doesn't necessarily run by the same title, but there are pieces of evidence that there might be positive benefits seen several years on for children. So there's definitely, but this is from very small studies. So there's definitely benefits to using the programme, and we just don't know how long they last for. But I think the points that you make of, and listening to the comments, really, there's such a shortage of resources, such a shortage of skilled professionals, that actually having these kinds of brief resources, however imperfect, is still a way of sharing really important information and making families absolutely central to, and caregivers central to the recovery of children in these kinds of contexts. So thank you for calling me on.
Thanks, Rachel. Thank you.
I see another question from Abdullah. Maybe this can be the last question. We are a little bit over our time. I don't want to keep anyone longer. Abdullah, please go.
Yes, thank you for interesting and amazing, beautiful this presentation. So I'm Abdullah. I'm working at awesome organization. So I'm working in the field and working with in TRT program, what you mentioned in this presentation. So there are many of children that have suffered from PTSD and working in TRT. So in your presentation, so you presented in model 4 model. So in the last model, TRT program is and plus programming parenting. So how to there is there any program to deal with a parenting program this in the field nowadays?
Salam Abdullah, thank you for your comment. I'm really glad to know that you're aligned and you're from Awesome. Awesome has been one of the most the biggest collaborators for TRT in the Syria and Turkey conflict response, and I know that a big part of our training coming up for TRT in the region will be to upskill more of the Awesome team. So far you have received the TRT component, and what will be happening is when we run the training in Syria and in Turkey, we will be running it for people who have not had any experience with TRT, so new facilitators. But for those who have had the TRT part, we will be adding you just for the part of the plus parenting. So even though you have TRT experience, you can join just the plus parenting day or 2 days of training.
Yeah, thanks. Thank you. Yeah.
Thanks, Abdullah.
Thank you so much for everyone. I'm just conscious of our time. I would like to express our gratitude and thank to Dr. Aala for today's extremely informative session. And we will be in touch with the following webinar series in Arabic and potentially in Turkish. We shared all the links in the chat box, but we will be sharing via email too. Thank you again so much. Ruth, would you like to say something as a closing mark?
Just thank you so much.
Thank you.
For the beautiful presentation and for the conversation as well. And just to reiterate what you said at the beginning, yeah, that it's such a difficult time that everyone is going through, and it's also an amazing opportunity to support families, to be those wings around the children, to help them.
Thank you, Ruth.
Thank you so much.
Thanks, Gulsar, again for inviting me to speak. It's been a pleasure.
Thank you all so much. And we will be sharing the recording on our YouTube channel so that you can access later on and share with your colleagues. Have a lovely day. Thank you.
Have a great day, everyone. Take
Thank
care.
you.
Bye.
Thank you.